techniques, new method of reconstruction, challenging cases. So there is about 10 posts per day we are getting in this group. So they about every month they selected a top 5 cases according to the challenges and the number of the comments and likes. They pick those 5 cases, and in those 5 cases they do a poll, in which all the participants take part, and the winner of that poll got the case of the month. So our institute won 4 times that award in all over the world, and this is the honor for us. Our department got as an invitation for a faculty from one of the most prestigious biannual conference of the reconstructive microsurgery, which is going to be held in the month of August in 2023 for the to show our workload. So now I invite Dr. Tushar to present the case of the Forefoot treatment.
Thank you, sir. Good morning, respected senior faculty, seniors and colleagues. Today I will be discussing the case. So we have a 3-year-old male child presented in the hospital with a history of tractor plugger injury while playing in the farm field. The patient presented with the amputation of forefoot. On general examination, the patient was vitally stable. There was no evident systemic finding present. On local examination, there was an amputation of talonavicular joint, with the amputated part was preserved in a plastic bag and kept in the ice. And the distal stump had a talonavicular joint with exposed flexor tendon, and the ligature was present over the dorsalis pedis artery, and there was no active bleeding. So what will we do next?
There are multiple options according to the surgeon, whether we go for the reimplantation or just discard the amputated part and go for the closure of that stump.
What is the difference in reimplantation and transplantation?
Sir, the transplantation, including reimplantation, means we are going to reimplant the part from the own body. While in the transplant, we have to take we need a donor, sir, from which may be the homolog from other person. Reimplanting means we are attaching the same part which is detached from our body to own body, sir.
You do transplant of a tooth from the same patient.
From same person,
You say
sir.
that same person. We have one that expression. The neural cavity appears. Then it is known as transplantation, not reimplantation. So what is the difference?
Sorry, sir.
यदि आपको दांत का कोई ऑपरेशन करना है, रिप्लांट करना है तो उसको
Yes, sir.
ठीक है ना, या ट्रांसप्लांट तो ट्रांसप्लांट को what is the actual difference in reimplantation and transplant?
Sir, reimplant is any part of the body which detached from our own body, sir, is reattached to on same place, sir. It's a reimplant, sir.
They will go from the foot and put it in place of a finger or a thumb.
Sir, it's called transfer of the, is a term of microvascular transfer of the toe to the thumb, sir.
Will that be called reimplantation?
No, sir, this is a transfer of tissue, sir. From like in microvascular surgery, if we are going to reconstruct the oral cavity or cheek skin, so if we are taking the flap, so it is a microvascular reconstruction of that part. Reimplant is attached to the same side from where it's detached, sir. And in transplant, we have to need an organ from other body to transplant it to the another person's body.
What I have read is the difference between reimplantation and transplantation. It is the reimplantation is for the acute emergency. You are not planning, just like this case.
Yes, sir.
Alright, in transplant, you have a time like kidney transplant or liver transplant. You can plan surgery. In the replantation, it is the acute emergency.
Yes, sir.
So it's the difference of time more important. Okay? You go through other definitions also. This is what I just well on my way to.
So, and this, yes.
Before we go into the transplantation or the implantation, if supposing somebody is on site where this accident occurs, what is to be done?
What is to be
done.
So that's why the next slide I am just discussing all these things. So whenever we are in such scenario where the patient part is amputated and we want to know कि now we plastic surgeon can do the best job. But there are a lot of the center where plastic surgery facilities are available. But there are few centers in the Jaipur, hardly 2 and 3, where reimplantation can be done. So we must know before referring the patient to any center for reimplantation, we know ki whether that center is well equipped with all the equipments and the facilities to underwent the replant. So the most important of these are what is the criteria for ideal replantation center. So it will must have a very efficient transport system in the form of the road or either air, and have a very well prepared emergency room with dedicated doctors of the emergency in emergency, so that they can evaluate the patient immediately and prepare that patient for the procedure. And also, sir, the center also have the well experienced around the clock team of the anesthetics, along with the well-trained operating rooms and operating staff in the operating room. The center must have high-resolution operating microscope so that we can replant the any part with, because this is a microsurgery, so we are dealing with the vessels which is about 1 to 2 mm of diameter. सर हमारे पास लाइका का है सर एक ENT माइक्रोस्कोप है, so we are doing all surgeries with this microscope. Sir, in plastic surgery department, sir.
Sir,
Yes, sir, we already give sir.
Yes,
That was my intention with Rajguru. He has rightly pointed out. I want to the very best. Like is also best.
Sir,
Not
like
the
I
best.
said, yes, sir. Like I already said.
Yeah, it's also from Germany, and the stone is also from Germany.
But sir, now the era of the super microsurgery has come, sir. Here, sir, super microsurgery, like we are dealing with the vessel size which is about 0.8 mm in diameter, less than 0.8 mm. So it is visible only with the high resolution, which has the about 30 or 40x of visual
What do
height.
you mean by 30 or 40x?
Yes, sir.
What do you mean by 30 or 40x?
Sir, the time of the magnification, sir, 40x.
कितना हो जाएगा magnification index? Because we deal as a specialist with all sorts of things. If you say 30x, that means 300 times magnification.
Yes, sir. We are dealing. If we are, sir, I will show in the next step. Recently, 1 month back, we did a reimplantation of a finger in 3-year-old child, which amputated the level of the proximal interferential joint. So in our microscope, we maximum magnification is 40 with eyepiece magnification of 0.6. So we did successfully reimplant that child. So and the experienced microsurgical team.
They have shown me some of the pictures.
Sir, like I previously said that any center who has microscopic surgeon doesn't mean that their center able to do a replant. So in a survey conducted in the America, and the center which have well-trained microvascular surgeon, only 56 center able to perform the replant surgery. And India, it is very less. It is 56 in America, but in India it is or very less in number. So the child was immediately taken to a hospital in Nagaur. So where is orthopedic doctors give him primary treatment. And the orthopedic doctor is very well aware about the organ, how to preserve the amputated part. So he clean that part with a saline and teach him how to preserve the part for the further transport in a proper manner. And he also gave the primary care in the form of the dressing to the patient. And the patient was referred to the government hospital for the MLC. Now, we have very time limitation in reimplantation surgery because we take the patient in the OT as early as possible. So there is time consuming between the MLC and the further process. So now the question arises, what is the ideal way to preserve the amputated part and how to transport? So this question is very important for our general residents, orthopedic residents, and the emergency doctors they face the same challenge. So how they teach the attendants how to preserve the part in proper way. So the question is arise. Anyone can give how to preserve an amputated part. प्लास्टिक how in plastic bag में कैसे करते हैं, कैसे उसको प्रिजर्व करते हैं?
I think from next time we will reserve these seats for final year residents. So all final year residents of all departments will sit here so that we know that who is to be targeted.
Eyes, yes, eyes. But in that direct contact with the eyes, and how? If you put the part in direct contact with the eyes, that it damage the tissue. Yes, yes. So this is the ideal way. Okay, you just first clean the part very well with the tape butter available here or with the saline. Then place this part in a well soft saline gauze, and that part should be kept in the polythene bag, and then that polythene bag in another box which is full of the ice. So this is the ideal way of transport the amputated part, because it increase the port ischemic time. So the interval between the surgery and the trauma is increased, and we can save the limb. There are many cases reported where we can save the limb part after 24 hours of trauma with the proper preservation of the part. So saline, not in saline, we wrap that part in a saline soft cloth and then put in the polythene bag, and that polythene bag is another box of the ice. No. So there are special solution for like जैसे we have liver transplant में specific होता है, लेकिन for the skin part we just lying. So I am very happy with when that patient came with in our OPD. The attendant has the how to kept with the ideal method to preserve that part. He came with this this ideal method. He put the part in the polythene bag and then in another box with the full of the ice. So then child was brought to the another tertiary care hospitals in Jaipur for the MLC and the further management, and then there he advised for the closure of the stump and revision and closure of the stump. But the patient attendant was not ready to accept that choice of the treatment. So he refused for such treatment for the treatment, and then so the question arises: is that the ideal management of this case? He just discard the part and just close the limb. No. The patient is well educated. He heard from media, print media, that any part can be reimplanted. So he refused for the treatment, and then he visited many hospitals in Jaipur. So for to save his child limb. Then after about 3 to 4 hospitals he visited, then someone advised to go for our Mahatma Gandhi hospital's emergency for the reimplantation. In the next day, in the 9 a.m., the patient came to our OPD for our consultation. The time, the lapse between the trauma and the first consultation is more than 16 hours. So the reimplantation is, so now the questions arise: what is the standard time, the lapse from the trauma surgery for a successful reimplantation? Within 6 hours. Yes. The 6 hours is the ideal time. It is means depend on the level of the amputation. If the patient came with the mid-arm amputation, where the more muscle mass, because the muscle have high metabolic rates, and within 4 hours the muscle cannot be survived. Start reperfused. So like from the mid forearm is 4 hours, wrist level 6 hours, or more distal part like thumb, like finger, where the skin and only the tendons. So you can up to 8 hours we can do the reimplantation surgery. So whether the reimplantation is possible in this case after 16 hours time lapse between the accident and our first consultation. So we counsel the patients about the success. There are very less chance as compared to the standard for the we can save this limb, and the method by which he developed is also gave us hope that we can save that limb. So what the challenge we are facing that time is a reperfusion injury. So what is a reperfusion injury? Whenever there is ischemia, then the oxygen free radicals are generating, and the leukotrienes and the cytokines are released in the systematic circulations. So they further damage the cells, further aggravating the tissue injury. So this is a paradox when the patient came after 16 hours. It can be prevented by there are many methods like free radical scavengers and antithrombotic drugs, hypothermia, other things. But in plastic surgery and microvascular surgery, the best way to prevent the reperfusion injury, you start the surgery, first anastomose the vessels, artery. When you start the artery, then the blood came from the venous veins and let the flow, so that all the toxic materials wash out. And when you see the improvement in the color from the dark red to the slightly dark, then go for the vein anastomosis. So by this you prevent the toxins, free radicals to enter into the systematic circulation. Otherwise, if in the major amputation, there are some cases reported when we do the reimplantation of the mid forearm or thigh level, then the patient died because of it's affect the cardiac functions, myoglobinuria, and multi-organ dysfunction. So we prevented that reperfusion injury by first anastomosis the artery, then let the blood out from the vein. Yes. Sir, yes. The next slide. This is another challenge we face is the use of the interposition graft. So vessel retract, but we can mobilize the vessels to some length. We can gain by the just by dividing their branches. So it depends about how many branches. Like vein, we can either intercommunicating veins, so we can divide that vein and get some length. So graft we can put. So in the same slide I am going to explain. You can see this is a suture. So when the patient first comes into the orthopedic person, there is profuse bleeding. So he just tie the bleeding vessels. So my message is that never, if you encounter any patient with the amputation, don't ligate any vessels. Just do a firm dressing to stop the bleeding. When you ligate the vessels, we lost a part of the vessels. And the second is the patient is young. Whenever we are going for the replantation surgery, there is some bone shortening is there. We always do some bone shortening so that we can achieve anastomosis or repair the vessels without the use of the interposition graft. But in some cases, when the length is we miss the length, then we can use the vein graft as a saphenous vein graft or from the dorsal aspect of the foot. Or arterial graft can sometimes we also use. So in this patient, we repair both the artery and vein with the use of the saphenous vein graft, which were taken from the opposite leg. And also the posterior nerve also repaired, which with the sural nerve. So from the same incision, we harvested both the saphenous and the sural nerve to repair the structure. Another is a prolonged ischemia time. Is another challenge we face in this case. So this is a study done by the Dr. Radha Savapati from Ganga Hospital, Coimbatore. So there are various guidelines following during the major reimplantation. So as we can say, is the maximum 8 hours is the safe limit between the time of injury to the surgery. Now the strength in our Mahatma Gandhi hospital is the operating microscope. We have the very good operating microscope and the microsurgical instruments. Like we said, this is one of the other case of the reimplantation we did 1 month. Now the era of the super microsurgery has come. So the part previously discarded, not considered to be reimplant, now can be reimplanted with the help of the high resolution camera and super microsurgery tools. So now we can reimplant the tips, fingertips also, sir. Distal to the DIP joint, nail bed amputation can also be reimplanted. And I'm also congratulate, thanks to our experienced anesthesia team, and that patient came in the morning, and immediately we approached to the Dr. Avnish sir and Gaurav Goyal sir, and they immediately take the patient in the OT, arrange all arrangement for the OT, and within 1 hour we start the surgery, sir. And any patient came with the amputation always need a multidisciplinary team approach, and our institute is very well equipped with the team of neurosurgery, orthopedics, general surgery, GI surgery. So we can now not also save the limb, but also save the life of the patient with the help of the multidisciplinary team approach. Now I invited to Dr. Gaurav Goyal and Dr. Aditi from the Department of Anaesthesia about how they...
Good morning everyone. On behalf of our HOD, Dr. Avnish Bhardwaj sir, I welcome you all, and I am thankful to the Academic Council who has given us the opportunity to present the anesthetic consideration of delayed amputated reimplantation surgery. A 3-year-old male child weighing 12 kg had tractor frugger injury involving amputation of distal 1/3 of foot. On arrival, child was agitated and crying excessively in pain and had cold peripheries. Screening of general condition was done to rule out other vital organ injury. After weighing pros and cons, it was decided to proceed expeditiously for emergency vascular reimplantation surgery under general anesthesia. Our main anesthetic consideration was following. As the patient belongs to pediatric age group and presented late to us, we wanted to avoid further delay because patient was in severe pain and agitated, as well as hypovolumic and hypothermic, and there was a possibility of electrolyte imbalance as well. There was a risk of hemorrhagic shock, acute kidney injury, acute renal failure, reperfusion injury, lactic acidosis, infection and septicemia, as well as trauma-induced coagulopathy. Intravenous cannulation was difficult as the patient was in hypovolemia and hemorrhagic shock. With the NBM status unknown, rapid sequence intubation was planned. Standard ASA monitoring was applied. Anesthesia was induced after pre-oxygenation. Sympathetic tone was preserved using hemodynamically stable anesthetic drugs like ketamine, fentanyl and atracurium. Intubation of trachea was done with appropriate size endotracheal tube, and the vitals of the patient was following. USG guided ankle block was given for intraoperative anesthesia and postoperative analgesia. ABG was sent to assess the spot hemoglobin level, metabolic status, renal function and serum electrolyte. To avoid hypothermia, warm IV fluid were given. Body temperature of 36 degrees Celsius was maintained with the body warmer. Hypovolemia and hemorrhagic shock was managed intraoperatively according to the vitals. Non-lactated crystalloids balanced salt solution was given, maintaining blood sugar level of 150 plus or minus 30 milligrams percentage. 1 unit of PRBC 60 ml given intraoperatively, and urine output of the patient was 0.5 to 1 ml per kg per hour. To maintain distal limb perfusion after vascular anastomosis with the consideration of trauma-induced coagulopathy was another challenge. Injection heparin 1500 units were given for the vascularity and thrombus prevention. There was a great chances of reperfusion injury in such cases. For that we monitor ABG based pH and lactate values. Sodium bicarbonate was given in calculated amount to correct metabolic acidosis. Duration of surgery was 5 hours. Intraoperatively, patient was responding to the intervention being done. Estimated blood loss was first 150 ml of total. The patient was sent to PICU on elective ventilation for correction of delayed metabolic derangements and confirmation of graft viability. Patient was extubated successfully the next day.
One basic principle of any presentation is don't write everything on the slide, because then you start reading it and audience can read it before you read it. Silent reading is always quicker than loud reading. So you must only write points and then explain so that you have an eye-to-eye contact with the audience. Dr. Gaurav, for the non-anesthetist, non-surgical audience, could you please explain what is this rapid sequence intubation?
Good morning all. So rapid sequence intubation is an intubation where we intubate the patient quickly without giving pre-oxygenation or time consuming 3 minutes. Right, 4 vital capacity breaths are required and equivalent to 3 minutes of 100% pre-oxygenation time. Right. The advantages of rapid sequence intubation is, first, there is no IPPV. So if the patient has taken something or fasting status of patient is unknown, there are chances while doing IPPV for regurgitation or Mendelssohn syndrome, what we called it as. So aspiration chances to prevent aspiration pneumonitis, in such cases it is advisable not for going for the positive pressure ventilation and you just go for rapid sequence intubation. That is to be done with the drugs calculated according to the ED95 doses. About 2 to 4 times of ED95% dose of any muscle relaxant can do it. Usually it is done by succinylcholine, or where the succinylcholine and depolarizing muscle agents are contraindicated. It usually done by non-depolarizing muscle agents like rocuronium, or can be done with other also when we are increasing the doses up to the 4 times of the ED95 doses.
Maximum rapid sequencing is done in obstetric emergency.
Yes, sir.
Doing cesarean section, emergency cesarean section.
So I think obviously all anesthesia, thank you sir, all anesthesia colleagues, all surgical colleagues and anyone who is doing any intervention under anesthesia should be aware of this, because every member of, it's not that I should have a attitude that it is the anesthetist's responsibility. No, if I know that I don't know the NBM nil by mouth status of the patient, if the patient has recently taken something, proactively I should inform my anesthesia colleague that be careful, this patient has just eaten a breakfast or whatever it is. Because it is everyone's responsibility to ensure safety. Sometimes in the hurry of things, we tend to forget what needs to be done. So if everyone remembers, it becomes multiplied.
Is it worthwhile to put IGT before doing tube surgery?
NG tube may be useful for emptying the stomach, but leaving an NG tube in situ is going to jeopardize the results. In fact, one technical point which was not leading check, the rest are incomplete. So, and posteriorly it is broader and larger compared to the anterior part. So, posterior broader part is compressed with the anterior pressure on cricoid cartilage by a trained assistant, and the esophagus is pressed between the cricoid cartilage and the anterolateral aspect of body of the vertebra. This is called Seilik's maneuver. And I'm happy to share with the audience and Honorable Chairman Sir that this pressure applied, the optimum pressure applied is considered a subjective thing, and they say that a 30 Newton force should be applied, and there is no way to measure it routinely. And we have developed a...
So the question arises, what is the order of repairing the structure? As we are going to fix the arteries, repair veins, tendons, nerve and bone. So can anybody can tell what is the order of repairing the structures in case of the amputations? Because we are going to, and then the tendons, then artery, vein, and lastly the nerve. The nerves repair is very underrated in all form of the amputation, because they always believe that nerve will not regenerate. But when you do in proper fashion, proper technique, It's always give you very beautiful results, like in the brachial plexus surgery. And so always is better to have a sensate limb than the insensate. Like in the lower limb trauma, there are only very few contraindications for the limb sealing surgery. First is very the damage which cannot be repaired, like there are multiple level of injury, and another is insensate too. This is also considered also as a contraindication for the limb sealing surgery. If you are repairing the tendon after the artery, then it's hampered with the our anastomosis. So just repair the structure like bone and tendon before the artery. This is some variations, like some sudden repair versus anastomosis. Then
If the tendon is away from your vascular anastomosis,
sir,
then you
tendon
could
line,
do it later.
yes, sir, tendon line in the center and the all vascular pedicle run in the mid-axial line.
Fixation will be better if you have the tendon repair.
So,
Bone fixation will be better if you have the tendon repair. The tendon attaches to bones. Bone की stability ज़्यादा हो जाएगी tendon repair. ये better.
no, sir, actually the any tendon muscles have tendon and the muscles, they have their origin and insertion. It doesn't usually बहुत कम होता है कि अपन जब amputation हुआ तो इस insert detach from their insertion. So the tendon जो होता है वो from always away, like in this case the insertion is over the phalanx, toe phalanx. So
will increase stability of fixation. Tendon अगर हम repair करेंगे तो stability बढ़ेगी.
yes, no, sir. Actually, is how to fill the tendon bone, sir. Then
कितनी बोरे हैं 4 front में?
किसमें sir?
4 front, 4 foot.
4 foot पे sir 5 to metatarsal हो गई sir, and phalanx up to 2 sir.
कितने में total?
15 sir.
Are you sure? 2 में कितनी होती है पहले दिन?
तो वो सर 2 होती है
और बाकी में?
बाकी में 2
10 हो तो?
10 12
3 में 12 4 के 12 तो 14 5 मीटर का तो टोटल कितनी हुई? I am talking very sensible. That is 5 metatarsals and 5 phalanges. Grade 2 has 2 phalanges. Rest of they have 3 phalanges. So it will be 14 phalanges and 5 making 4 foot. How much the dorsal foot? How many bones?
dorsal sir, talus navicular and
I'm asking just number. Because if you know the things, then you can better replace.
sir, but they are orthopedics people know by but
No. This is a shortcut and very flimsy answer, and you must know the anatomy. You should know the bone anatomy, you should know the tendon, you should know the muscle, incision, attachment, and you should know the artery, you should know the vein, you should know the nerve. Everything you must know. And fascias also. So you cannot say that I am plastic surgeon. It's not my job. It's the job of orthopedics. And vice versa.
so the reimplantation surgery is a two-team approach. So while our anesthetic team evaluate the patient, first we evaluate the amputated part, whether it is suitable for the reimplantation or not, because maybe there can be a multiple level of injury. So first we evaluate the amputated part. We dissected all the structure that need to be repaired, like tendons, artery, veins. We tag it with the help of the sutures, and when we find it is now suitable for the reimplantation, then we take the patient in the operation theatre. And like this, we have our team. We first all take all the essential structure with the help of the nylon suture, artery, vein, tendon, and nerve. So now I invited our orthopedics colleague who did a very good job by fixing the part with the Dr. Ashwini and Dr. Rajat.
We have only 15 minutes to meet you. Sorry, we have been interrupting you. Good morning, respected seniors and colleagues and juniors. So here we have a patient with midfoot amputation. Part of the fifth metatarsal was preserved. If you would appreciate, here is the fifth ray was present, and rest four toes, fourth rays were with the amputated leg. And on X-ray we can see the amputation was from the mid-tarsal joint, talus and calcaneum were preserved with part of the fifth ray. So what are the aims in this replantation surgery? First, we have to give a good looking and functional limb and restore the limb appearance. The other chance, how we do it? Usually in reimplantation surgery, we need to do shortening of the limb to gain the neurovascular structure and the reattachment of the neurovascular structure and the tendons. But here, as the patient was 3-year-old child and the amputation was from mid-tarsal level, and orthopedic surgeon at the first chance where the patient reached, he already ligated the dorsalis pedis vessel. So, as we already discussed with the plastic surgery team that here they will use the graft for the neurovascular structures. So we decided not to shorten the limb. In other cases where where we have to do the shorten the limb in young patient in younger than 18 years where the growth is there, we can do shortening up to 8 centimeter. But here in the foot cases or in the hand cases, we don't do shortening. Plus the child is 3-year-old. And the second issue is which implant to be used. To gain the full strength of the limb and to give a stable joint, we usually do in initial stages external fixator. But here we have to do the tendon repair, vessel repair, and child is 3-year-old and has to gain the develop the foot structures also. So we decided absolute the external fixator and used a thin K wire to prevent the growth center and prevent to damage the cartilage structures. So here you can see we have used 3 K wires. First wire we use the transverse wire to keep forefoot amputated limb of the forefoot, this part, with fifth ray. You can see the part of the fourth ray, fourth metatarsal was also paired with the fifth ray. So we used a transverse wire through all 5 metatarsals and 2 wires, one through the first metatarsal to the talus and second through the third metatarsal to the calcaneum. It gave us the stability, though it was not 100 sure stability, but as we knew that we were going to suture the skin and the tendons or the neurovascular structure, it gave us the relative stability at that time. And after closure of all the structures, it will give the proper stability. So with minimum time and relative stability, we achieved the proper length and the stability of the limb. Thank you.
I think the ortho residents and maybe surgery residents also have to understand what was explained, that there are 2 options. In order to have a tension-free anastomosis of vessels and nerves, either you shorten the limb or you don't shorten the limb and you use a graft to cover the defect in the reconstruction of the vessels and nerves.
So this is a video of vessels anastomosis with the help of the cutaneous vein grafts. this is the immediate intraoperative picture of blood coming, bright red blood coming out from the grade 2. This is a picture on the second post-operative day. We could not save the first foot toe because there is multi-level of injury, and it's also supply came in the zone of injury. So it start discoloring, showing changes on the second post-operative day. And this is a picture after 1 month because actually we start the prolonged ischemia time, so intravascular thrombosis start developing in the most distal part. So there is some gangrenous change also found in the distal toe. So with sorry sir, and artery. So and the intravascular thrombosis start developing from the distal most part. And these are some of the relative contraindications of the implantation. Almost any part which is amputated from body can be reimplanted, but there are very little contraindications in the form of the systematic and the local factors. And the post-operative protocol of the use of the anticoagulation in the form of the low molecular weight heparin, dextran, and the aspirin. Is surgeon preference what anticoagulation of this choice. So the monitoring of post-operative monitoring, the normal circulation has pink color, there is good capillary fill time, warm, turgor is full, and bright red blood. If there is arterial thrombosis, then the turgor is decreased and the limb is cold, and there is minimum bleeding. And when venous of thrombosis, the capillary fill time is brisk, and the blood coming out is dark red. So
keep that slide for a minute. So surgery resident, when you get a case of peripheral vascular disease, except dermal bleeding, don't break the vision to induce bleeding, but all the other things you have to describe. That is how you present a case of a vascular.
Our future plan in this patient is removal of the gangrenous part, and then after removal of KY, we will send the patient for the physical medicine and rehabilitation for the movements. And this is the picture of the happy patients with their happy faces. So even there is slightest possibility of the implantation, never should not be missed. So 4 days back. Sir, it starts regenerating because you use the sural graft. So after 1 month, it will start at a rate of 1 centimeter per day, sir. So will take time, sir. About 3 to 4 months, sir. 4 months, sir. So moment after removal of KY, because there is little possibility, so we just take the tendon and we do the reconstruction the next second stage, sir.
What level you have
So the foot toe is completely gangrenous, and there is some skin gang part is gangrenous. So we need to remove, and depend the kind of size of the defect. Either we heal by the second intention, or we apply some graft. And even there is slightest possibility of replantation is never be missed. Otherwise, the patient came with the lifelong disability and always need to wear the prosthesis, lifelong, which has the possibility of the torn and damage. And why we choose this case for the fissure? Because this is one of the case of the successful implantation after 16 hours ischemia time. This is one of the youngest case of the foot implantation in the world. The other case published is a similar 3-year-old child in the China. There is no reported case of the foot implantation in India in literature. And it is also the case of the implantation with use of the vein graft, because we have to deal with the 2 anastomosis in single repair while the use of the vein graft. And in our take-home message, it is our responsibility to raise awareness about the preservation and transport of the amputated part, and the reimplantation is possible in today's world, irrespective of the level of amputation. I told we can reimplant the nail bed also now this time. And also thanks to our Mahatma Gandhi media team who raised the awareness by the print and digital media about the how to preserve and what to do or don't in case of the amputation. And this is a picture depicted one of the miracle by the Jesus Christ. So when he raised the Lazarus, one of his beloved followers from his death, 4 days after his raised 4 days after his death. So reimplantation restore life to the lifeless extremity, which is considered like a miracle in the modern surgery. So I also thanks to my Dr. Manish Kakkar sir, Dr. V.K. Kapoor sir, and Dalit Mohan sir, and our residents and our faculty who helped me and guide us for making this presentation. Thank you.
Small question to the surgery residents. If there is an injury at the terminal part of the finger, what percentage of xylocaine and adrenaline will you use for local infiltration? Answer. What concentration of xylocaine and adrenaline would you use to give local anesthesia in the finger? Anybody? So, like Dr. Anish said, it is an end artery. So, you should never use adrenaline when you do a local infiltration. Only use xylocaine and never adrenaline. Otherwise, because it is an end artery, the finger is going to damage.
Same applies for circumcision or partial amputation of penis also. Yes.
जमाने में जो रिमोट एरिया में सिजेरियन वगैरह करते थे तो जैलोकेन के साथ नॉरेड्रेनालिन लगाते थे टू प्रोलॉन्ग
To prolong the anesthesia time, then we need adrenaline. Yes, sir.
But
So there are two benefits of the use of the adrenaline. It's increase the local anesthetic effect and it also help you achieving the bloodless speed, sir. The time, sir, there is one paper published in which that...
सर एक्टोपिक प्रेगनेंसी की शॉक में पेशेंट था. सुनो मेरी बात तो सुन लो आप. और नहीं terminal phalanx I agree with everybody, but in spinal anesthesia, suppose not be able to give general anesthesia and using little bit of noradrenaline to overcome the shock by the time you are giving the IV another thing. And you know the time of surgery may extend 45 minutes, 1 hour. There is no harm and Avnish will give the correct opinion. Of course, G is there and we are working in a tertiary hospital.
Now many local analgesics are available which are having duration of 3 to 4 hours. So you need not use adrenaline. Second, if you use adrenaline in spinal, it is going to cause more time getting scored.
Sir, but it is also helping the achieving the bloodless speed.
Some senior surgeons in
toxic contributed to those yes. So that is one advantage. But yes, there is a flip side.
I mean, some senior surgeons instruct their team not to have any xylocaine with adrenaline in the minor OT, so that by mistake also it is not given. So that is taking it extra safe. So 2 or 3 points where I would like your approval and permission. This is a very important social service. Because when we remove a large tumor, we get huge publicity. That is less important. This is very important. 3 things need to be done from the hospital. 1, that we need to organize more and more meetings at periphery where this case should be presented as an example to teach general surgeons, orthopedic surgeons, trauma surgeons, emergency doctors that look, it is possible. Still the awareness may not be there. Fortunately, here the parents were educated and they made every effort to come to us. Second, lay media. Public has to be taught. So yes, we have had some coverage, but I think it needs more coverage in both print and the visual media. And third, I would request that from the hospital side, the orthopedic surgeon who gave correct instructions to the patient should be publicly kind of recognized by us for immediate advice which he gave. That will send a good message, and that also should get media.
Go to different hospitals
Thank you.